Good day. Thank you very much for attending the RSNA boost for lung mediastinum and pleural case-based multidisciplinary review. I'm the moderator, Simon Lowe from University of Washington, and Dr. Subha Digumarty from Mass General Hospital, Harvard Medical School, Dr. David John Stone from Medical College of Wisconsin, and Dr. Christina Baig from University of Washington, and Fred Hutchinson Cancer Research Center, and Dr. Spring Kong from University of Hong Kong, and Case Western Reserve University. Just to say hello to everyone. So these are our disclosures. So Dr. Johnstone, do you want to present the first case?
So the first case is a 66-year-old male smoker who had a preoperative chest x-ray for a minor procedure. At that time, a right upper lobe density was seen, which was not present 1 year prior.
So Dr. Subha Digumarty, do you want to comment on this case?
On this frontal view of the chest, I see a nodular opacity overlying the anterior right first rib. This is a spiculated nodule, and this site is highly concerning for primary lung cancer. Otherwise, I do not see any other significant finding on this radiograph. On the CT scan, there is a spiculated nodule in the right upper lobe, right next to the right brachiocephalic vein. This corresponds to the nodule seen on the radiograph. There is also a small paratracheal lymph node which measures less than a centimeter in short axis. On the fused CT and PET images, the nodule in the right upper lobe is intensely FDG avid, and this would be highly concerning for primary lung cancer. The paratracheal lymph node does not show uptake which is above and beyond the mediastinal blood pool, so this is not significant uptake.
So the patient had a chest CT and PET that we've just looked at. They showed a spiculated 3 centimeter right upper lobe mass and a 9 millimeter paratracheal or level 4R lymph node. There was no other evidence of local, regional, or metastatic disease. The patient also had a brain MRI, which was normal.
So it is important to assess the lung cancer before any treatment is given to determine the TNM staging. Of these three, the T is very important. The T stage of a lung cancer depends on diameter, the location in relation to the lobar bronchus and carina, the presence or absence of distal atelectasis or pneumonia, invasion into the chest wall or into the mediastinum, and presence of other lung nodules. A nodule or a lung cancer should be measured in its longest diameter. This can be located in any of the planes. It can be axial, sagittal, or coronal plane. And based on the size of the tumor, a number of T stages can be given. So in the current edition of TNM, which is the 8th edition, a total of 7 different T stages can be given. And these stages are given based on the size, and the determination they use is the increment of 1 centimeter. As the tumor increases in size, the prognosis gets worse. The presence of mediastinal invasion can be determined if there is gross replacement of the mediastinal fat with the tumor, or if there is gross involvement of the mediastinal vascular structures or mediastinal viscera such as esophagus or trachea. So these cases obviously are surgically inoperable. These by default are T4 tumors. If the chest wall is involved, we again look for definitive signs of chest wall invasion, such as destruction of the bony structures such as rib or costal cartilages, and presence of soft tissue mass within the musculature of the chest wall. If these are present, again, this is definitive sign of chest wall invasion. A chest wall invasion makes it a T3 tumor, and in many centers, if the tumor is otherwise operable, surgeons will go in and resect these tumors. The presence of a nodule within the same lobe as the primary tumor makes it a T3 tumor. The presence of a nodule in the same lung but in a different lobe makes it a T4 tumor. The size of the primary tumor in these cases does not matter. Involvement of the carina makes it a T4. In most situations, these are surgically inoperable cancers. Involvement of the diaphragm also makes it T4. These patients tend to have poorer prognosis. So based on the imaging findings, this tumor measured slightly less than 3 centimeters. So by T stage, it will be T1C. And because on imaging, I did not see any significant lymph nodes, it will be N0. Now there was any presence of distant metastasis or intrathoracic metastasis, therefore it is M0. So clinically, it will be stage 1A.
So this patient had a history of COPD. His FEV1 was 57% predicted, and DLCO was 70% predicted. He had a 30-pack year smoking history and had mild dyspnea with exertion. He was, based on this, a candidate for a lobectomy for his presumed clinical stage 1 lung cancer. He underwent a bronchoscopy with planned mediastinoscopy and right upper lobectomy. The bronchoscopy was normal. The mediastinoscopy, however, found involved level 4R paratracheal lymph nodes on frozen section. And at that point, the plan for the lobectomy was abandoned. And the patient had a surgical stage of T1C N2 M0 adenocarcinoma of the lung, stage 3A. So that was the clinical stage based on the frozen section. There is some discussion should be briefly made about the routine use of mediastinoscopy or endobronchial ultrasound for mediastinal nodal staging. For most patients with clinical stage 1 lung cancer who have no evidence at all of mediastinal lymph node involvement, most surgical oncologists would defer a formal EBUS or mediastinoscopy because the odds of involvement of the mediastinal nodes approaches the false negative rate of those tests. In this patient, we felt he was somewhat higher risk due to his pulmonary symptoms. In addition, patients who have large primary tumors, certainly 4 centimeters or greater, or those who have suspect hilar adenopathy should undergo either mediastinoscopy or endobronchial ultrasound prior to resection of the involved lobe or lung. In this case, the decision to abandon the lobectomy was based on findings of N2 disease prior to entering the chest. There was the possibility that the level 4L or level 7 stations, also biopsied in this case, would turn positive on the final pathology. And multi-station N2 disease has worse prognosis than single-station N2 disease. Overall, there are better outcomes with a combination of chemotherapy and radiation, with or without surgical resection, compared to surgery alone for stage 3A lung cancer. There are some subset analyses that have shown that single-station N2 involvement, particularly with upper lobe tumors, may do well with resection followed by adjuvant therapy. We did not know for certain that that was the case in this patient's situation. The role of post-operative has been a matter of debate over the last couple of decades, and whether it would be appropriate in this patient after a lobectomy is a matter of preference and some debate.
So Dr. Johnston mentioned that in this case, we would consider chemo plus or minus radiation followed by surgery. And one of the questions sort of in regards to the basic principle of treating lung cancer patients is why we would do that first in a resectable patient. And really, this is based on the fact that despite having local disease or locally advanced disease on imaging, many of these patients, and actually majority of patients, will recur systemically. And that's particularly true in stage 3 disease. So the idea of induction treatment is that we would treat micrometastatic disease early. So that's one of the rationale for starting with induction systemic therapy. Now, another benefit of starting with treatment or systemic treatment is that we're able to do an in vivo evaluation of tumor biology, meaning that if patients receive induction treatment and after that they're found to have a new metastatic lesion, and certainly we have seen those cases, these patients really would not have benefited from upfront surgery. So in a way is to select for patients who are going to have a bad tumor, as we call it, upfront. Now, of course, there are downsides to this approach in that one of the big possible downside is that there are patients who do have complications from systemic therapy, and this may delay surgery. So there is certainly need to select patients carefully.
To Professor Kong.
Yeah, agree with Dr. Johnston and Beck. For stage 3 resectable, for this case, T1 and 2, treatment option we have just surgery followed by systemic treatment or radiation, or induction chemotherapy followed by surgery, or chemo-RT followed by surgery, or just chemo-RT alone. Next one. So for chemo-RT alone without the surgery, the evidence is very strong for stage 3 concurrent chemoradiation followed by immune therapy. The famous Pacific study, they randomized a patient, stage 3 patient, to adjuvant Duva versus placebo after concurrent conventional chemoradiation. Go to next. There was a significant benefit of adding Duva adjuvant chemotherapy in progression-free survival with a hazard ratio of 0.51. And the median progression-free survival was 17 months in the Duva group versus 5.6 months in the placebo group. And next one. And the survival was also strikingly different, significantly, remarkably different. With Duva group have median survival has not been reached, with a 5-year survival recently reported for this stage 3 patient reached 47, about 50% of 5-year survival. So this is numerically, although not a direct comparison, better than almost all the surgical report for surgical Syria of stage 3, about 5-year survival, only about 30s. Go to next. So for resectable neoadjuvant, the other option is concurrent chemo-RT followed by surgery, and this is for this case actually quite relevant and the patient really fits to the intergroup study population. N2, single N2 resectable could, according to this intergroup study, actually reported a better overall survival in the trimodality concurrent chemoradiation followed by surgery if a patient have lobectomy. The improvement was a significant progression-free survival for all patients, but no improvement for overall survival for all patients together. Go next. The reason of no improvement on survival is largely due to the high perioperative mortality from the pneumonectomy group. Pneumonectomy group here, you see the mortality of 26% in a limited number of patients, although versus 1% in lobectomy. And pneumonectomy had a significant higher risk of preoperative death is also demonstrated by other series. This is another series showing similar result, and I'm sure there are other series in the literature as well. Next.
So, Dr. John Stone, from the surgeon's perspective, how do you see the results of this trial?
So I think that we felt that the mortality from pneumonectomy was certainly excessive, above what we would experience from pneumonectomies without induction therapy. We would quote a mortality rate of perhaps 5% for pneumonectomies generally. Most of these deaths were right pneumonectomies. I think most of us who were involved with that trial or have done similar types of treatment have had experiences with right pneumonectomies going on to postoperative ARDS and dying or developing bronchial stump leaks and the complications of that. So I think that there has been debate in the surgical literature. There were a number of centers that, following this trial, published series from their centers or combined centers that did not seem to show a higher mortality rate with pneumonectomy after induction chemoradiation. Nevertheless, I think this is a landmark study, and it has been a cautionary tale to the surgeons. We do think generally that a lobectomy in this setting is a safe operation without excessive mortality, and therefore, at my own center, for example, we would probably be very cautious about recommending pneumonectomy after chemoradiation in these patients, but would willingly perform a lobectomy if possible.
Yeah. Now, from radiation oncology point of view, actually, after pneumonectomy, the risk of death from fatal radiation pneumonitis are also very high. Pneumonectomy is definitely not something we would like to see in the in radiation part. The treatment, I think, the trimodality. Benefit of surgery is also limited in the aspect of study. Actually, patient treated with chemotherapy followed by concurrent chemoradiation and then randomized to surgery versus no surgery. There is no significant difference in progression-free survival or overall survival. Next. Now, for this patient, if we're taken to surgery, many of the surgeons would do that, though there will be N2 disease. Even there's no additional lymph nodes, there will be surgical N2. Surgical N2 setting, as Dr. Johnston mentioned earlier, the role of radiation has been of the debate. And the evidence of a supporting part study for N2 disease is demonstrated by a few limited study subgroup analysis. This is the study actually from Anita showing a detrimental effect for N0 and 1, but some significant difference benefit for N2 disease. Go to next. Next. And here shows you more on the NITA study. You see those N1, N0 disease. The median survival was about 1 year or even long for N1, for example, 1 year less those receive post-operative radiation. But for the N2, the improvement, median survival improvement was like a 13 months better for the chemotherapy group. For the the significant for N1, if a patient receives chemotherapy, the survival is also worse when those receive radiation in a chemo setting. Now, a NITA study was a study randomized to compare the different compare the effect. The survival impact of adjuvant chemotherapy. Pod radiation was not specifically designed, was a kind of random based on physicians' preference in Europe because physicians have a different pattern of practice on. So the study allowed institution make a decision either radiation or not. So the comparison may not be as strong, but this data have very strong opposite result. Next. So come back to to the NCCN guideline, you're also demonstrate the options for we just discussed about for stage 3 as definitive chemoradiation or induction chemotherapy followed by radiation or surgery. Next. For the So radiation has a different dose of radiation. And I want to hear what Dr. Johnston got to say about high dose radiation.
So the 9309 trial that was really done in the late 80s and mid 90s took patients really to 45 gray or so. The trial listed here took patients to about 60 gray. And it was a feasibility phase 2 trial that demonstrated that surgery after radiation of that dose combined with chemotherapy was feasible without excessive morbidity or mortality. Next slide. Simon, I've lost your screen.
Yeah, cannot see anything.
Okay, yeah, I paused it. So let me see what happened. So, do you see it now?
Yes.
Okay, we can continue.
Okay. So the next slide. So this patient actually was enrolled in RTOG 0839, which was a phase 2 study of pre-op chemoradiation plus or minus panitumumab, surgery, and then consolidation chemotherapy. The primary endpoint of that trial was clearance of mediastinal nodal disease on the theory that the addition of the panitumumab would improve that. This patient was randomized to the control arm, so did not receive panitumumab. The trial ultimately did not show increased nodal clearance with the EGFR monoclonal compared to chemo alone, and the experimental arm came with higher toxicity. So this is the restaging scan after chemoradiation and prior to surgery. I can let Dr. Digger-Murphy comment.
The nodule in the right upper lobe has now significantly decreased in size. As you can see, it has become more longer. It was more plump before. The paratracheal lymph node that was positive on mediastinoscopy also has shown some decrease in size. So this is consistent with a good response after therapy.
So the patient had a repeat brain MRI that was negative. His pulmonary functions actually improved somewhat, and he underwent a lobectomy and mediastinal node dissection. His postoperative course was complicated by middle lobe pneumonia, evident on his postoperative chest X-ray. He went home on short-term oxygen, but recovered from this. His final pathology showed only a 4 millimeter focus of tumor remaining in the right upper lobe mass, and his final stage was YP, T in situ, N0, M0. He went on to complete 2 cycles of consolidation chemotherapy. He then had a series of follow-up CAT scans, which showed the appearance of a left upper lobe nodule that waxed and waned. I'll defer to Dr. Digamurthy to go through these.
Thank you, Dr. Johnston. So after the pneumonia in the right middle lobe, the patient had this CT scan which showed a nodule in the left upper lobe, which has decreased in size. The convention is if a nodule decreases in size, it is thought to be inflammatory nodule. So, but then this nodule completely regressed, but in the same location, a nodule reappeared that was increasing in size subsequently. So this is now concerning for a cancer. So I do not know if this nodule corresponds to the nodule which resolved before, or it's a completely new nodule. Next slide, please. So this nodule increased in size over next few months, over 2 years, and this is consistent with a cancer. The question is it a new cancer or is it a metastasis from the cancer that was resected? So it is no good way to answer this question. The way we would approach in imaging is, if this nodule has developed within 5 years, it is reasonable to assume this is metastasis. But because this patient did not have any other evidence of nodal disease, no other evidence of metastasis, and because this patient is a smoker who tend to have multifocal cancers in either synchronous fashion or metachronous fashion, it is also reasonable to assume that this is a new primary cancer. The only way to definitively prove one way or other is to do a biopsy and to show that this histology of this new nodule is different from the cancer that was resected. We can also show in terms of mutations. So this nodule is highly concerning for lung cancer. Subsequently, it has become even bigger and has developed a cavity.
So the patient had a bronchoscopy done at 32 months when it appeared in the center panels here. And unfortunately, that was non-diagnostic. Based on this and its subsequent growth at 36 months, he was treated empirically with SBRT. He received 40 gray to the overall, but I'm told received 50 gray to the gross tumor volume. These are his follow-up films after SBRT, and I will again defer.
So it is important to appreciate the changes which occur after SBRT. Initially, after a few days, the tumor itself shrinks in size, but then subsequently you see more inflammatory changes in the surrounding lung parenchyma, which should be consistent with radiation-induced pneumonitis. Then over the course of next few months, up to say 18 months, the radiation zone decreases in size. It becomes more flat, and it is more has an extent in the AP axis. That is a normal evolution of a post SBRT cancer. When the nodule becomes more nodular, when it starts increasing in craniocaudal direction, or when it starts developing lymphadenopathy, we get concerned about recurrent tumors of the treated lung cancer. So here, the first was immediately after SBRT, which shows the mass decreasing in size with a cavity. Then it started developing some rounded contours anteriorly and posteriorly. Then the mass started reaching into the hilum, And in the final image on the bottom, you also see endobronchial component. So these findings are highly concerning for recurrence of the cancer after SBRT.
So this patient declined further diagnostic procedures in terms of bronchoscopy, et cetera, and developed a COPD exacerbation and led to a episode of fatal hemoptysis at home.
So, Dr. Dukumarty, can you comment on, as a diagnostic radiologist, a chest radiologist, how do you distinguish between tumor progression and post-treatment changes after SBRT for lung tumors?
This is actually not that easy. In the conventional IMRT, we had more handle on how tumors would behave. But SBRT, because of high-intensity radiation delivered over a short period of time, the changes can be sometimes be different from what we expect. Now, this is a typical pattern of one case, a different case, where the patient had a tumor in the anterior aspect of the lung. Immediately after SBRT, the tumor has decreased in size. Then at 5 months, you start seeing all this radiation pneumonitis, which settles down at 16 months. The tumor treatment area starts shrinking. At 20 months, it becomes a band-like structure. But when the patient started recurring at 31 months, you can see the posterior convexity of the treatment zone, which has assumed a bigger size at 37 months. So this is a clear-cut case where you can say, okay, this patient has had a good response for at least 30 months, then the patient started recurring. But in SBRT, there's also what is called as a tumor-like inflammatory change. So many times we also see a tumor, which a radiation zone, which looks like a mass. But when we biopsy it, there's actually no tumor. So this is something is somewhat frustrating for us, but we have to individually assess each case.
So, Dr. Dukumarty, so what do you think is the role of PET scan in the evaluation of post-treatment changes?
Yeah, in the immediate post-treatment period, the PET can be hard because of inflammatory change. But after a few months, if you start seeing localized FDG uptake in one part of the treatment zone, that should certainly raise a suspicion for local recurrence in that particular location.
So, Dr. Johnstone?
In this case, I concur that the presence of this new contralateral nodule in the left lung raises the question of whether it's a metastasis or a new primary. I agree completely that it's impossible to know in a patient who's had a new nodule within 2 years or 3 years of a primary stage 3 lung cancer, to know, short of a biopsy showing a different histology. Even if it had shown an adenocarcinoma in this patient, it may have been a separate adenocarcinoma, a new primary. So I think the approach to these patients has to be individualized, and if the scenario looks convincing for a new primary, the patient should be treated aggressively for that, if possible.
Yeah. So for this case, from radiation oncology point of view, I think for the risk of metastasis or new primary, the HACC and the expert consensus normally would treat this kind of case as a second primary, unless proven otherwise. Because that's the give opportunity of cure for patient. Otherwise, the outcome is too small. For the empirical SBRT, there are significant amount of data from mostly initially from Netherlands group, recently Canadian and Chinese group, American group, the Japanese study was showing without biopsy for clinical diagnosed either primary lung cancer or metastatic, SBRT has shown similar result as those with biopsy. So it's a consensus, expert consensus. When there is no biopsy, I would normally do with multidisciplinary tumor board discussion, documenting the clinical diagnosis and providing patient understand may not necessarily need a written consent, but they understand no biopsy, and that could be small cell cancer, small cell lung cancer treatment may be a different small chance. But give SBRT, it's a consensus recommendation. For this case, I think we gave 40 grade, Dr. Johnston, maybe a little bit low side. Some other physician will give a definitive dose of probably 50 grade in 5 for this case, or 20 grade in 20 grade times 3. So
yeah, I think this patient received 50 grade gross tumor volume.
Okay. So for complication, for this patient, the bleeding, a lot of people actually fetal massive hemoptysis is the main cause of death after SBRT for central or super central or central located tumor. For these cases, not really central located. I would doubt, I think we have a slide later on to show that the isodose plane, but I would doubt it was radiation related. But for non-small cell, for lung cancer, actually cancer progression induced death. For a primary tumor like this case, he does have like about 20% of risk, 10 to 20% risk of a nodal failure, and the higher lymph nodes progression cause death is definitely a possible reason as well. Next.
Yeah. So I have one question for Dr. Dukumarthi. So when you evaluate like a nodule on a CT scan, what features would point to like a benign nodule versus like a lung cancer or like a metastatic lung tumor?
The best thing is to look at the stability of the nodule. If the nodule has been stable for a long period of time, it is a good indication that it's probably a benign nodule. Sometimes you're lucky enough to see fat in the nodule or calcification in the nodule. If you see those two, that is indicative of benign process such as hematoma if they're seen together, or if it's only dense calcification, that could be a granuloma. But the most important thing is the growth. How fast is the nodule growing? A nodule that is growing too fast is probably inflammatory nodule related to infection. A nodule which has slightly slow rate of growth, doubling time of over 30 days, but less than a year, is probably indicative of cancer. But then we also see many of these indolent lung cancers, particularly subsolid nodules. So these are some of the things we take into consideration.
So Dr. Bake?
All right, so let's move on to the second case. So this is a 56-year-old woman with a history of prior stage 1 right breast invasive ductal carcinoma. She was diagnosed in November 2016 and had treatment. And 1 year later, she presents with an acute left-sided rib pain without any other systemic symptoms. So she does not have a lot of past medical history other than the stage 1 breast cancer, which was ER/PR positive, HER2 negative. She did have a germline BRCA2 mutation, so her treatment was quite extensive, which included bilateral mastectomy and salpingo-oophorectomy, followed by hormonal treatment. And she does not have a smoking history. So because of the rib pain, she initially started her workup with a plain film, and that led to the subsequent imaging studies, and I will defer to Dr. Morty to comment on them.
So on this CT scan in the lung windows, you see a speculated nodule measuring slightly over 2 centimeters in the apical posterior segment of the left upper lobe. This by itself is highly concerning for primary lung cancer. On this image, there is no lymphadenopathy, there is no other satellite nodules within the same lung or in the contralateral lung. So now, focusing on the pain this patient has, this nodule is highly unlikely to cause pain. So I'd be interested to see some other images. So the nodule itself has got increased FDG uptake that will be consistent with a primary lung cancer. But there is also another focus of increased FDG uptake that corresponds to the 10th rib on the left side. So this is highly concerning for a metastasis. Though this patient does not have nodal disease, it is known that lung cancer can sometimes skip the lymph nodes and can have distant metastasis either in the thorax or outside the thorax.
So before I go on to the next point, I would like to ask Dr. Johnstone about his thoughts on where to biopsy and your rationale for choosing one site versus the other.
Ideally, one would want to biopsy the area that would yield the most advanced stage if cancer was found. In this case, the rib would be that site, and that should be feasible percutaneously or surgically to biopsy the rib. If that were positive, then the patient has stage 4 disease. Biopsying the lung mass would still leave the question of whether the patient has bone metastasis.
Thank you. So the patient did end up having a biopsy of the left 10th rib lesion. One thing I would say from the perspective of a medical oncologist is that, as of a few years ago, even though biopsying a bone lesion would give us staging and diagnostic information, often we would ask the interventional radiologist to perhaps biopsy a different lesion if there was one, just because doing molecular testing, which has become increasingly important in lung cancer, has been difficult on a bone biopsy because of the processing issues, especially with the decalcification of a bone biopsy, where we would not be able to do molecular testing due to DNA denaturing. Nowadays, that's something that we can deal with because the processing can be done with something like EDTA. These days in most academic centers, we are able to do bone biopsies for molecular testing as well. So the patient did have molecular testing using the bone biopsy, which revealed an EGFR deletion 19 mutation. So because on her imaging, and I should mention that her brain MRI was negative, so because our imaging showed that there appeared to be 2 areas of disease, one in the left upper lobe lesion, the second being the rib lesion, at our institution, what we decided to do was to refer her to our thoracic surgery colleagues for a mediastinoscopy with the idea that if there is no mediastinal involvement, that we will consider upfront surgical resection to both lesions. Now, let me pause here and again ask Dr. Johnston's opinion about this approach and whether he would take a different approach here.
I think that approach is reasonable. The data we have on results from anatomic lobectomy for T1 and 0 M1 bone lesions with bone resection are very limited. Most of the data we have for surgical resection up front for stage 4 disease with single Mets is from brain Mets and some from adrenal. And there may be some slight survival or some, acceptable survival levels with that approach. In this case, I would agree mediastinal staging has to be done. If that were negative, I do think it is reasonable to consider a lobectomy and rib resection. This is convenient in this patient because the rib involved is on the same side as the lobectomy, so that can easily be done with one exposure in one operation. What would your surgeons do if this was a right-sided rib lesion, for example?
Yeah, I think what we would have done if the mediastinoscopy is negative would have been that the patient would have had a left upper lobe lobectomy and likely radiation to the rib lesion because of the same points that you're making in terms of the not exposing the patient to two different resections. So the patient ended up having a mediastinoscopy, and despite the fact that her mediastinum looked unremarkable on the PET scan, she had multi-station and 2 disease with both stations 4L and 7 being involved with carcinoma. So upfront surgery was no longer recommended, and systemic treatment was recommended instead. So a quick slide on how we treat EGFR mutated lung adenocarcinoma is that essentially we treat it with an EGFR directed drug. Historically, it used to be erlotinib or gefetinib. Nowadays, osimertinib is a preferred third-generation EGFR inhibitor based on a study called FLORA. And on comparison, osimertinib was significantly better in terms of progression-free survival and overall survival. And as you can see here, the response rate is 80%, disease control rate of 97%, meaning that the majority of patients are having either tumor shrinkage or at least stable disease. And this is very durable. In PFS, progression-free survival was close to 19 months. So patients can have very good disease control for almost a couple of years with just a pill. But the problem, of course, is the fact that patients will eventually progress. And at that point, treatment options are more limited. So I started this patient on osimertinib. She was on it for about 3 months. And I should also mention that she also received palliative radiation to the rib lesion prior to starting osimertinib. And after 3 months, I'm not showing the images, but she had a very good response. At that point, I referred her to our radiation oncology colleagues for discussion of either consolidation radiation at that juncture versus deferring it until disease progression.
So the role of radiation for oligomets for this case, it's evolving. For this specific patient is EGFR positive actually. The primary, the treatment option we can do target therapy followed by radiation of the primary and the metastatic disease, or I think, sorry for this one. I think for these patients, EGFR positive, let's go next. Next one. So the first question is the radical treatment in oligomets non-small cell lung cancer. Really, the treatment outcome for this group really actually relatively good, comparable for stage 3 as you look into different subgroup of patient, even for N2, consistent with AJCC staging data, even N2 5-year survival about 13%. For if it's N0, you could be up to 45-year for like almost 50% 5-year survival, excellent outcome. So definitely depend on the patient overall condition and the risk factors. The survival outcome varies with different kind of a treatment. Go next. For consolidation local treatment, the first randomized study reported, actually quite small study from MD Anderson, initiated from Dan Gomez in oligomets patient for after systemic treatment. This is not a target though. It's a not mutation negative patient. They randomize to consolidation radical treatment, including surgery or radiation versus maintenance treatment per treating physician. About in the group received radical treatment, 24 of 25 of them actually received radical radiation therapy. Next. This study report outstanding local progression-free survival, first report in ASCO 2016 in plenary section, showing tripled progression-free survival with the consolidation treatment arm, and that was published in Lancet Oncology. Next. This is showing you the detailed result, the progression-free survival of the consolidation versus versus the conventional treatment regimen. Next. For patients with mutation, EGFR mutation or ALK fusion positive, the treatment radical treatment also reported improvement of progression-free survival and overall survival. The series are much smaller actually. For the EGFR group was not a randomized study, but again the numbers showing outstanding progression-free survival of 15 months and median survival 20 months. That's with inclusion of EGFR positive patient, not purely EGFR positive. Next. So this is the series, just reported. I mentioned a little bit earlier, a very small study with another series from UT Southwestern. 29 patients randomized to SABRE versus maintenance treatment. You see the significant difference in progression-free survival with the SABRE group. That's radical ablasive radiation. And then remember, Gomez was conventional radiation, not ablasive. Next. Here shows you the numbers. The patient after this is EGFR negative patient is compared to SBRT versus no SBRT. Median survival of 9.7 months versus in the SBRT group versus 3.5 months with p of 0.01. So SBRT met the primary endpoint and really striking result. And the concept is now there's a multi-center energy oncology study ongoing in a phase 3 setting to evaluate the value of SBRT. This is SBRT for metastatic sites. The SABRE COMET study is actually from it's inclusive lung cancer, not all lung cancer. It's all metastatic cancer, 5 lesions or less, compared to SBRT versus standard of care. The small number of non-small cell lung cancer. Go to next. Here again shows you the red line shows you the number of lung cancer patients involved included. But the SABRE, the difference in terms of progression survival and overall survival of the SABRE group is very similar to previous study. So this study was actually recently updated for updated results, showing long-term results just recently reported. With longer follow-up, the survival difference are greater. So those receive a more radical treatment, they the longer you follow up, the bigger, the greater magnitude of a difference in survival going to be as was seen. Next. Interestingly, there is no significant difference of quality of life. It's good also to know that the long-term results showing no detrimental impact, not only in quality of life, but also to long-term late toxicity. So aggressive SABRE or SBRT treatment for those stage 4 cancer patient did not change quality of life, did not increase toxicity, significantly improve survival. Next. So radiation effect in stage 4, local, not only radical treatment, even palliative treatment make a difference. Keynote 001 is a Pembro study. Actually, radiation was not designed to look into UCLA, just look into the patient treated in their center, compared the patient received radiation versus non-radiation. 43 of these 97 patients reported had radiation. Those received radiation, unplanned radiation, had a significant better progression-free survival, 6 months progression-free rate, median overall survival, and without the increase of lung toxicity. I think this is another study from Europe, actually, the Pembro SBRT. So SBRT was in combination of immune therapy in those patients randomized to intention to treat of SBRT versus non-SBRT as a study of 78 patients. You see those receive SBRT of 8 grade times 3 to the single metastatic site had a significant better progression-free survival as well as overall survival, borderline significance. Go to next. So with this data, although none of them are big phase 3 study or a small series of phase 2 randomized or not, NCCN actually recommend patient for stage 4 after systemic treatment, either after targeted therapy if you're mutation positive, or mutation or wild type after systemic treatment. They will recommend a definitive local treatment to metastatic sites, or definitive treatment to thoracic primary. If a primary is with nodal involvement, you radiate all the residual tumors. If a primary is only primary tumor without a nodal disease, you can consider SBRT radiated primary tumor. Go to next.
Yeah, thank you for attending this session. Bye.